Hello, my name is Charles Shearer. I'm a neuro-optometrist and also serve as a consultant to Vertec Corporation. Today we're going to bring you a video that's a little bit different. This video is directed more towards the primary care provider. And the purpose of this video is basically to show them what they might be able to do as a screening for risk of fall, but also for them to understand what the balance specialist does. Feel free to share this video with anyone you'd like. We're basically going to cover why we do them, who should do them, and how they're done. What does Medicare consider a fall? Well, of course, they've got their own unique definitions, but officially it is defined as a failure to maintain an appropriate lying, sitting, or standing position, resulting in an individual's abrupt, undesired relocation to a lower level. In other words, what they're trying to say is it's not just falling from a standing position, but it also could be falling from a chair or falling out of bed, those types of things. The statistics related to falls are really kind of amazing. The second and third one are the one that stands out the most to me. One is that it's the leading cause of death from accident above the age of 65. And 1 out of 5 falls above the age of 65 results in a serious injury, a broken bone, or concussion, that type of thing. And the costs are staggering. Whose job is it to be concerned about a patient's risk of fall? Everyone's. With those statistics in our aging population, we need to get as many people involved in screening for risk of fall as we can. And that includes physicians, physical therapists, occupational therapists who may not be balance specialists, may have more of a primary care flavor, optometrists, even dentists, but also I've highlighted in red the caregivers and family. They're the ones that see them the most often and can help with probably the most accurate checklists and surveys. How do we determine a person's risk of fall? There's really 4 unique categories. The first 2 are able to be done by the primary care practice, and that's surveys and observations and risk of fall screenings. And once they've detected a patient being at a risk of fall, then they would refer to the balance specialist who would do the more extensive risk of falls evaluation and also instrumented risk of falls. And we'll go over these as we go along here. The first one is basically an extended case history. I personally go out and room my own patients. I like to see them stand up out of the chair and walk back and kind of observe their balance, and also are they hanging onto the walls as they're walking back, that type of thing. Careful case history is important. Then there's the list of provider questions and patient questionnaires. I'm amazed that if you simply ask 2 questions of a patient, have you fallen in the last year, or are you afraid of falling in the next few months, that you'll pick up about 70% of the patients who will fall within the next year. And this is how we would score those questions. If they've fallen in the last year, then they automatically would become a risk of fall. But then when you ask these other rating questions, it gets even more intense. The CDC is a wonderful resource for surveys and referral forms and everything else. Here's a checklist that is used to evaluate risk of fall, which asks the same 2 questions, but obviously quite a few more. And the more questions you ask, of course, the longer it takes, but also the more information you get. And this is another checklist that they have. And, you know, if you look in here, it's cognitive impairments, are the medications they're on, and those types of things. From the eye doctor's standpoint, several of the questions refer to, can the patient see 20/40 or better? And basically, have they had an eye exam within the last year? When they come into us for an eye exam, the things that relate closest to fall risk are visual acuity worse than 20/40. 20/40 is also the referral and cataract criteria set forth by Medicare. The patient needs to see 20/40 or worse before they are allowed to have cataract surgery. This really needs to be updated. You don't want them to get that bad before you're allowing them to have cataract surgery. Contrast sensitivity is another very important measurement. It basically identifies how well you can see an object against its background. Depth perception, less than 85 seconds of arc. Peripheral awareness, or basically is like peripheral vision, but it's a little bit more than that. It adds a cognitive component to it. And then bifocals, trifocals, and progressive lenses can be a risk of fall for many patients if they're not instructed properly on how to use those. I feel that the primary care practice can also do some very simple tests well within their realm, and they don't take that long. So the first one would be the sit to stand, timed up and go, and a 4-stage balance test. And as well, they could have an acuity chart there to do a vision screening. We'll play a quick video here on how to do the 30-second.
The 30-second chair stand tests functional lower body strength. To administer this test, you'll need a chair with a straight back and a stopwatch. Place the rear legs of the chair against a wall so that it cannot slide backwards. Have your patient sit towards the front of the chair and fold her arms across her chest. Ask her to keep her feet flat on the floor and sit upright. She should try to stand up, keeping her arms folded across her chest without pushing off with her arms. When you say go, she should stand up all the way and then sit back down, doing this as quickly as she can until you say stop. Arms should remain folded across her chest throughout the test. Stand close enough so that you can catch the patient if she loses her balance. If the patient gets tired, she may rest, but let the time keep going. If she cannot stand even once, the test score is 0. Not being able to stand up from a chair without using one's arms to push up indicates a high risk for falls. Record the number of times the patient stood up in 30 seconds. If the patient is over halfway to a standing position at the end of 30 seconds, count it as a stand. Now, based on the age and sex of your patient, find their normal range on this chart. If your patient's score is below the norm for his or her age and gender, it indicates lower body weakness, a risk factor for falling. If the patient can't stand up even once without using her hands, allow her to push off using a hand on the chair. Be sure to document any adaptations. The test score is still 0 for purposes of comparing to normative standards, but this way her personal performance can be evaluated from one assessment to the next.
Again, here is the scoring grid there, and you can tell there's a difference between men and women, of course. The next test that they could easily do in a primary care practice is the tug.
Stand up and go, or tug, tests functional mobility. To perform the test, you need a chair and a stopwatch, or a wristwatch with a second hand. Have your patient start by sitting on the chair, feet flat on the floor, one foot slightly in front of the other, and hands on the armrests of the chair. Put a line on the floor 10 feet or 3 meters away. Ask your patient to stand up from the chair and walk at her normal pace to the line on the floor when you say go. When she reaches the line, she should turn around, walk back to the chair, and sit down. Be sure to start timing on the signal go, and even if your patient has not started to move, and stop timing at the moment she sits back down in the chair. While she's walking, stand between the chair and the line in case the patient loses her balance and you need to assist. Observe and note the patient's posture, width of the base of support, step height, stride length, arm swing, and path. When the test is complete, record the time. Also record whether the patient used an assistive device, and if so, what type. A community-dwelling older adult who takes more than 12 seconds to complete the tug is at increased risk of falling.
And again, there are several studies that have different times for that. Another study would quote 13.5 seconds, but in that range. The third test that I would suggest a primary care practice could and should do is the 4-stage balance test. And once again, we have a video to demonstrate that.
The 4-stage balance test assesses static balance, which is an important part of postural stability. To perform the test, you only need a stopwatch. Tell your patient that you will show her 4 positions and would like her to try and stand in each position for 10 seconds. She can hold her arms out, or move her body to keep her balance, but should not move her feet. For each position, describe and demonstrate it, and then stand next to her and hold her arm if needed to help her assume the correct foot position. When your patient is steady, you can let go. Say ready, begin, and begin timing. But you should stand close enough so that you can catch her if she loses her balance. After 10 seconds, say stop and record the time she was able to hold the position. If a patient can hold a position for 10 seconds without moving their feet or needing support, go on to the next position. If not, stop the test at this point. For the first position, the patient should stand with her feet side by side. For the second position, she should place one foot so it is touching the instep of the other foot. For the third position, she should place the heel of one foot in front of the other foot, touching the big toe. For the fourth and last position, have the patient stand on one foot. An older adult who cannot hold the tandem stance or either of the two prior stances for at least 10 seconds each is at increased risk of falling.
Again, we should emphasize that particularly for the last two tests, you want to be pretty close to them in case they do tend to fall so you can catch them. Now what? Well, once we've done the primary care screening, if they have been determined to be a risk of fall, that's when we would encourage the primary care practice to refer to a balance specialist. And here again, it's a nice referral form that I suggest that is provided by the CDC. And we want to educate the primary care practices as to what a balance specialist does. And that's the next section of this video. Again, I'm not going to go into each test in this video because it would take way too long. But we just want the primary care practice to see some of the tests that are done. And the three tests that you can do without instrumentation that are probably the most valuable are the Tinetti, the Berg, and the Modified Clinical Test of Sensory Integration and Balance. Here's a worksheet for the Tinetti test. And again, it takes about 20 minutes to do this test. And it gives you information beyond what you can do with just the tug or the sit to stand. The Berg test is similar. It has a little different emphasis, but it gives, again, a lot of the same information, and it's preferred by some practitioners over others. The Modified Clinical Test of Sensory Integration and Balance is quite valuable because of its ability to differentially diagnose. It helps you determine whether it is a vestibular problem, a visual problem, or somatosensory. Now let's talk about the instrumented evaluations. This is our specialty, of course, at Brewtech. And they can do multiple things. To say the least, an instrumented version of the Modified Clinical Test of Sensory Interaction on Balance, limits of stability, unilateral stance, sensory organization test, motor control test, adaptive test. And with the new head-mounted display, we can do subjective, visual, vertical, and horizontal. A few words about the new head-mounted display. It is very cost and space effective, and it lets us do sensory evaluations for response inhibition, spatial memory, perception span, and reaction training. And on the visual side, we can do head tilt response, or rod and frame, subjective visual horizontal, and subjective visual vertical, and visual flow. Again, here's a quick picture of the head-mounted display in use. And we can do these sitting, and we can also do them standing on the balance board. I want to thank you for your attention. Please watch for more videos in this series. They will be more directed to the balance specialist. This one, again, we'd love to have a lot of primary care practices see these so that they can screen patients for risk of fall and make referrals to the balance specialist. Again, thank you for your time. And for more information on the new VR system, please visit our website.